Okay, good evening, everyone. So we will continue our lecture about the TDM of digoxin. Yeah, and so as we know that clinical uses and doses of digoxin, it is mainly used for two indications. Yeah, which is atrial fibrillation and atrial flutter. Yeah, and heart failure, but for both indications, actually digoxin is a bit outdated. Yeah, so digoxin is no more first line. Like for atrial fibrillation, it is now second line. Yeah, do you know what is the first line for atrial fibrillation? To slow down the ventricular rate. What will be the first choice? Yes, Ivy. What will be the first choice for to slow down the heart rate in atrial fibrillation? It's quite commonly used.
Amidron?
Yeah,
Amidron?
amiodarone. Yeah, but actually amiodarone is more, is an anti-arrhythmic drug which we keep it first for a more severe one. Like for example,
Yes,
ventricular tachycardia and all this. Yeah,
yes.
but there's one drug that is, one or two drugs that are commonly used. I mean, it's
Calcium
safer
channel
to use.
blocker or beta
Yeah.
blocker?
Yeah, beta blocker.
Calcium channel.
Yeah, beta
Uh-huh.
blocker or calcium channel blocker. Yeah, these two. Okay, so but if the patient has a heart failure, yeah, so the alternative is digoxin. Okay. No, so digoxin, so for atrial fibrillation, we need rapid digitalization normally, yeah. So we aim to achieve around 1 milligram, yeah, 1 milligram orally over 24 hours. So normally we give it in 3 doses, yeah. So like 0.25, 0.25, 0.25 like that, yeah. 3 to 4 doses, yeah, in one day, yeah. And maintenance according to renal function and loading dose is around 125 to 250 microgram. Yeah, that is the normal typical doses. Okay, for heart failure, actually the doses a bit lower for heart failure. Yeah, because why? Because later on for heart failure, we don't have no need to achieve um, uh, very high concentration. So the plasma concentration for heart failure is lower. Okay, so this is the figure that typical doses from 62.5, yeah, to 250 in microgram. Yeah, and then target range will be, this is the target range from 0.8 to 2. Yeah, so these are the therapeutic. Yeah, and above that, above 2, yeah, so it is approaching to toxic level. Okay, especially above 3, yeah, it will be very toxic. uh, so loading dose and maintenance dose, we can see, yeah, digoxin also can be given by IV. Yeah, by IV. So if we want, if the patient cannot swallow and we want a faster digitalization, we can give it by IV. Yeah, also oral elixir, etc. Yeah, and so these are the kind of doses that we give. And for bioavailability, of course, if IV, it is 100%. Intramuscular is not recommended, but it is around 80%. Oral capsule around 95, yeah. Tablet 75, elixir 80. But actually, for tablets, yeah, so it is from 60 to 80. So it depends lah, yeah. So normally we take 70, the average 70 as a bioavailability. Now, for therapeutic range, as I mentioned just now, yeah, for heart failure, okay, it is 0.5 to 0.9. Also, I forgot to mention, even for heart failure, now digoxin is second line. Yeah, first line should be beta blockers, CCB. CCB is not that good, yeah, for heart failure. Okay, beta blockers and then S inhibitors. Yeah, these are the first line drug. Okay, and I just want to know whether you understand why, for example, like why you give beta blocker for heart failure. What is the rationale? Why you give beta blocker for heart failure? Isn't it
It has less side effect.
uh, when your heart is weak, yeah, heart failure, when the heart is weak, if we give beta blockers, isn't it will be aggravate the, I mean, the heart failure? Will it not become weaker because beta blocker will cause heart rate become slower, and then heart force contraction also become less, right? Because you are blocking, yeah, blocker. So but why we give for heart failure? So in the earlier, like maybe 10 to 20 years, yeah, especially 20 years ago lah, yeah, 20 years ago, beta blocker is said to be contraindicated for heart failure, yeah, as what I mentioned just now. There's a chat. What is this? Yeah, beta blockers noted to reduce. Oh, to reduce cardiac output. So dia, if you reduce cardiac output, it will be detrimental, isn't it? Because you need to increase cardiac output. Yeah. For heart failure, already you have reduced cardiac output. Yeah. So so it is quite strange why you use beta blockers. So as I mentioned previously, beta blockers are contraindicated for heart failure. Yeah, but after huge trial, yeah, after year 2000 above, yeah, so beta blockers are now even recommended, yeah, and now even the heart failure guidelines, it says that everybody with heart failure, stage 1 to up to 3, I think, yeah, so must be given beta blockers unless if they are contraindicated. Yeah, why? because because there are two ways to improve your heart function. Yeah, one is because now you have lack of cardiac output, right? Your to provide for the demand of the heart, isn't it? So now you are two ways. Yeah, let's say if you are tired, yeah, there are two ways. Either you take rest, yeah, or you force yourself, yeah, drinking coffee and all this. Which one you take? Which one, Ivy?
To rest.
Yeah. So uh pity Dia's microphone not working. Yeah,
To
correct.
take drink
To
coffee.
reduce to to reduce the apa? The stress of the, yeah, the, we call it the workload of the heart, yeah. Because beta blocker, you slow down the heart rate, yeah, so it reduce the workload of the heart. So your heart is already tired. So there are two ways to deal with it, to reduce the work of the heart so that the heart won't be too tired, yeah. But last time last time people are more aggressive. Yeah, you give digoxin. What is digoxin? Digoxin is um, what do you call this? Positive inotropic, right? Positive inotropic. It means that you make the heart contract harder. Yeah, positive inotropic. So you are kind of forcing the heart, yeah, to forcing the heart. So let's say you're talking about exam, yeah, because the exam is tomorrow. So now you're forcing your body, drinking coffee, taking all these supplements, yeah, forcing your body. Will it that be good? If it is for one day, probably okay, right? Let's say for one day only, yeah, you didn't sleep for one night, still okay, yeah. After exam, you can sleep puas-puas, yeah. Sorry Allah. I use bahasa word. You can sleep kau pula, kau bahasa word pula ya. You can sleep as long as you want after the exam, right? But if it is for every day, you will collapse at the end. Correct or not? Yeah. So the principle is that you give theta blocker to preserve the heart. Yeah. So make the heart less stress. Yeah. Less workload. So you actually prolong the life of the heart. But if you give digoxin, yeah, you may improve the symptoms. Yeah, like the heart failure symptoms may improve. But after certain time, the heart becomes so tired. Yeah, it will stop because you are forcing it, working so hard. Yeah, so tired. So in the research, yeah, research evidence saying that digoxin does improve the symptoms, yeah, but it does not improve the mortality. Yeah, it means that although the symptoms improve, but the mortality does not improve. It's not improved. Yeah. Okay, so but digoxin is still until now one of the drug for heart failure. Yeah, if the heart failure, because heart failure got a few types. Yeah, especially got two types. Yeah, one is with the preserved EF, another one with the reduced EF. Yeah, so the reduced EF one, you can use digoxin because the EF is so low. If the EF is so low, like the heart failure stage 4, and you give beta blockers, yeah, the heart will become slow, very slow until the blood pressure is very low, yeah, and that also you cannot function, right? If you don't have enough blood, although you want to preserve the heart, but the heart cannot even like pumping effectively, so you eventually also will die because you have lack of oxygen. Yeah. So in that case, then you have to use digoxin. Understand or not? Yeah. So that is quite interesting actually, the heart failure lecture. Anybody giving you heart failure lecture in the MFAM? Have you done the heart failure lecture? Okay, so we mentioned, so these things, yeah. So the heart failure, you need only lower concentration, but for the um, AF, yeah, you may need a bit higher, yeah, a bit higher, yeah. So it overlaps, yeah, like one you can achieve like maybe 0.8, yeah, it overlaps, okay. But in general, you need higher for AF, yeah. Some people even need until 3.1, yeah, milligram microgram per liter, okay. Now, for the pharmacokinetic parameter, yeah, the distribution, it is highly distributed to lean organ tissues, yeah, like heart, muscle, kidneys, and liver. And in fact, digoxin's mechanism of action will be in the muscle, right? Especially heart muscle, yeah, because we want it to affect the contraction of the heart. So it has to be highly distributed. So if it is highly distributed, it means that it will have a high VD. Yeah, the volume distribution is high, around 5 to 7, yeah, liter per kg. Yeah. Now serum to cardiac tissue concentration approximately 1 to 70. So more in the cardiac tissue, yeah. Like if you have 1 gram per liter in the serum, you have 70 gram per liter in cardiac in tissue. Yeah, distribution decreased by co-administration of quinidine and in patients with renal impairment. Okay, so the VD will decrease in renal impairment. Yeah, and decrease also when you are using quinidine. Now, quinidine also is used for for arrhythmia. Yeah. So excretion is mainly renal excretion unchanged. Yeah. 50 to 70. So 50 to 70% is renally cleared. Yeah. That's why our application of this is we have to adjust those in the kidney failure. All right. So primary glomerular filtration with some tubular secretion. And elimination non-renal also they are, yeah, some 30 to 50%, primarily through biliary and intestinal tracts with some gut flora elimination. Small amount through metabolism. Digoxin is a substrate for P glycoprotein, and concentrations are impacted by polymorphism and drugs that alter PGP. Yeah. So PGP, what is PGP? PGP is the substance, yeah, or molecule that acts as a pump. Yeah, it pumps out the drug, yeah, for from the um, from an organ. Yeah, for example, if you're talking about kidney, yeah, or intestine, so it will pump out from the intestine, for example, so the absorption will be more. Yeah, in the kidney it pump out, so it will be more excretion, yeah, in the kidney if you substrate to the PGP. And protein binding around 20 to 30% reduced during hypoalbuminemia, but 20 to 30% is quite low, yeah, compared to like warfarin 90%. Yeah. And then the clearance, yeah, if you see the clearance for adult, yeah, see dosing strategies later on. Yeah. So for the clearance, 1.5 plus minus 0.5 liter per hour per meter. So this one means that when you already at when children are already admitted and going to be given digoxin, so we can calculate from here lah. Yeah. So the clearance, yeah, this is the clearance. So if you see, it means that um, the clearance of infants, yeah, is higher than children, yeah, and also higher than adults. And volume distribution, so if you see neonates 10 to 1, yeah, infants 16.3, children 16.1, yeah, and adults 6.7. So adult actually has a lower VD, yeah. So when patient weight is used in V calculation, volume of distribution, IBW is used for patients whose actual weight is more than ideal body weight. Yeah, so why we need to calculate, pay attention to this ideal body weight and actual body weight. Yeah, because actually for the Cockcroft and Gold, yeah, we are using ideal body weight. Yeah, and V is decreased, meaning that the number of what is V just now? Yeah, the number of volume distribution. Yeah, volume distribution is decreased In patients with renal impairment, yeah, see dosing strategy. So I think where's the dosing strategy maybe? Hmm. Hmm. So a reduced total loading dose should be used for renal impairment. Now the half-life and time to steady state, yeah. If we see like premature neonates and infants, yeah. So the smaller they are, they have the longer half-life. It means, yeah, their metabolism, because they would probably lack of enzyme to metabolize this digoxin, yeah. So for adult, I think yesterday I mentioned for adult or the previous lecture, yeah. For adult is this 36, yeah, around 30 to 46 milligram. Um, no, this one is half life, yeah, hours, 36 hours. So in patients with normal renal function, this one A, yeah, A, time to steady state, yeah. 5 half-life using 1 standard deviation. So time to steady state is 5 times of this half-life. Yeah. Okay. So in patients with normal renal function, half-life is more than 4 days in anuric patients. Yeah. So anuric patients mean very few, yeah, very little urine. Okay. So the half-life is more than 8 days. Okay. Now, our key parameters, yeah. So optimum sampling time, yeah. Pre-dose, normally we take the pre-dose or the trough sample, yeah. And we have to do it to take this sample, yeah, above 6 hours. Yeah, why above 6 hours? Meaning that after the last dose, yeah, we take around 6 hours after that. Why? Anybody knows? Why we can't take immediately after taking after administration of the drug? Anybody?
Wait for the distribution.
Yeah.
Have to wait for the distribution.
Yes, distribution. Yeah, wait for the distribution phase. Okay. So wait for the distribution phase, meaning that when the drug has already gone to post distribution phase, or we call it also terminal phase, or we call it also elimination phase. Yeah. So time to peak 1 hour, rate of elimination 60%. Yeah, yeah. So around 60% excreted renally. Elimination half life 36 hours. Just now we already mentioned. Yeah, but normally I just memorize it as 35 rather than 36. Yeah. Time to steady state around 7 to 10 days. So around 1 week, yeah, to 10 days. Binding, total protein binding, 23 milligram. Yeah. And then target range just now, we already, yeah, see it. Yeah. Okay. What are the factors affecting concentration? Yeah. First is, of course, the renal elimination. Yeah. So extra care needed in patients with impaired renal function and in elderly. And then drug interactions such as antacids, cholestyramine, and dietary fiber decrease absorption. Okay, and enzyme inducers like phenytoin and rifampicin will increase the non-renal clearance. Yeah, and then small changes in dose may result in either loss of efficacy or serious tambat energy. Ano? So bioavailability. So bioavailability, what is bioavailability? So if you are using the oral one, yeah, so it can vary between preparations. So we can't just interchange it saja-saja, yeah. You cannot just what they call this interchange it freely, yeah. But of course, when we have got yeah so we have to know, for example, when just now we already see whether it is tablet or IV or capsule. Yeah. Now, side effects and toxicity, the most common gastrointestinal, yeah, nausea, vomiting, diarrhea, constipation, and abdominal pain. Neurological can be headache, fatigue, insomnia, confusion, and vertigo. Visual, this one is very typical. Yeah, visual disturbances, blurred vision, color cast, and colored halos are classical signs of toxicity, the digoxin toxicity. Yeah, cardiac effect. Yeah, we'll have the bradycardia, yeah, atrioventricular block, heart block, yeah, and ventricular tachycardia and elements dan lain-lain, ya. And then arrhythmia, ya, arrhythmia. Toxicity is related to drug concentration but is exacerbated by hypokalemia. Okay, so we must take care if we are using thiazide diuretic, for example, cholesterol, and what do you call this, toxicity. Yeah, so by hypokalemia, so hypokalemia will aggravate. Yeah, so it won't probably increase. It won't increase the concentration. Yeah, but it increases sensitivity. Yeah, later on I have got one slide for that. Okay, age and the severity of heart disease are also independent risk factors. Yeah, and development of yeah. So what do you call this, toxicity, hypokalemia, age and severity of heart disease are also independent risk factors for the development of toxicity. Yeah. And then severe toxicity can be treated with anti-digoxin antibody, digibind. Yeah, but unfortunately, it is not available in Malaysia. Okay, how do we monitor the therapy? Blood should be taken at least 6 hours post-dose to allow distribution to occur and ensure plasma concentration reflect tissue concentration. Yeah, so it means that just now the distribution IV mentioned, yeah. Plasma digoxin and plasma quotation should be measured, yeah, because the toxicity of digoxin increase in the presence of hypokalemia. Lower digoxin concentrations are now recommended in heart failure. Yeah, so just now you mentioned already, yeah, if for heart failure, we need a lower concentration. Endogenous, now this one is important. Endogenous substances, yeah, may cross over in English. Cross endogenous substances may cross react. So it means there's a cross reaction, yeah, in digoxin immunoassays. So digoxin like immunoreactive substance, DLIS, and yield spuriously means maybe here there is, yeah, and then some And then spurious means wrongly, yeah, wrongly high results. So it is inaccurate high result, yeah, because beside digoxin there are other endogenous substance that can react with this immunoassay, yeah, more prevalent in the very young, particularly neonates and the elderly. Now, what are the factors which increase tissue sensitivity to digoxin? Yeah, so hypokalemia, yes, now we mentioned, yeah, and then hyperkalemia, hypothyroidism, and hypoxia, and yeah, hypoxia and acidosis. All right. And then factors which decrease tissue sensitivity, yeah, that's hyperkalemia, hypocalcemia, hyperthyroidism, and neonates. Okay, so what about this population data to estimate the clearance? Yeah, so we can estimate clearance by using this data. Yeah, so this one if heart failure absent, so no heart failure. This one if there is a heart failure. Yeah, so from this formula, what do you think about heart failure or non-heart failure?
Which one?
I said that why? What is it? Why this one? If you compare these two formula, right? When there is a heart failure, there's 41, and there's no heart failure 20. So actually, this 41 and 20, it is actually the hepatic metabolism. Yeah, it's the hepatic metabolism. So it means when there is a heart failure, there is a lower hepatic metabolism. Can you think why if heart failure, then the metabolism is decreased? Yeah.
Because low distribution.
Yeah. Yes. Here Dia already also answer low blood circulation, which is correct. Yeah. Because if you have metabolism, where's the metabolism in the liver, and then in the liver you have to bring first to the liver, yeah, through the blood vessel, yeah, portal vein, okay. And if your blood flow to the liver decrease, so it will decrease the metabolism as well, yeah. So if the metabolism decrease, the clearance will be decreased as well. So another method, yeah, is this one, okay, using this method, yeah, and then this one the creatinine clearance, yeah, times 1.02. So these two are almost the same actually, yeah. So we can choose which one to use, yeah, because we just need a creatinine clearance. Now method 3, yeah, you already have the okay, another method. This method is the same also using the creatinine clearance, yeah. And then here, this method, this one, yeah, also using the creatinine clearance for patients with, yeah, if you have time, you can compare, yeah, with all this method, yeah. And another method 5, predictive performance model based on creatinine clearance values and ideal body weight, yeah. So almost similar, okay. So if so our here, if the dosage, yeah, less than 1, so if the D less than 1, so digoxin dose is 0.0625 milligram daily. But if 1 to 2, so digoxin base is digoxin dose is 0.12. So this one is, so if more than 2.5, yeah, and then digoxin dose is equal to 0.25 milligram. Yeah, it means a higher dose, Yeah, all right. So for kidney failure, so our dosage adjustment, if less than, so this one is end stage, yeah, so we only retain 10 to 20%, 10 to 25%, yeah. Now we give the interval every 2 days, yeah. So if 10 to 50, then 25 to 75, we give every 1.5 day, yeah. So but above 50, then we still give 100%, interval 24. We can also use pharmacokinetic calculation to adjust the dose, yeah, like what we have in our calculation. Measure the plasma concentration, find the clearance, and calculate the new dose to achieve desired concentration. Yeah, because of high VD, digoxin is not effectively removed by hemodialysis. In toxicity cases, digibind, yeah, antibody that binds to digoxin is used. However, this is not available in Malaysia. Okay, so now we have our TDM case. Yeah, Devi, 72-year-old, 160 cm, 66 kg, is a heart failure patient who is currently receiving metoprolol, perindopril, and furosemide. She has been hospitalized 3 times in the past year for her heart failure. At this time, her physician wishes to initiate digoxin therapy. Her current serum creatinine is 88.4 micromole per liter. Okay, so we can calculate the body weight is 66. So we try to calculate the ideal body weight, 52.2. Yeah, and then we can put into this creatinine clearance. Yeah, using the one that I provide. Yeah. So we get this one is the creatinine clearance. Yeah. 41.76. I don't know whether you get the same or not. Okay, Ivy, can you try to share your calculation, please?
Sorry, sir. This one I forgot to calculate the IBW.
Oh, it's okay. Oh, I just want to see your the way you calculate lah.
Oh,
Number
okay.
A.
Number A.
It's a bit hot for me. I turn on the aircon first. You can share the screen, yeah, because I already put share. Everyone can share.
Oh,
You
because
share
I
it.
didn't use the IBW, so yeah. The creatinine I got is 50 something. The formula I use is the one sir mentioned just now, the creatinine clearance.
Mm-hmm. So you get the lower or higher category? Higher, yeah.
Because I used the higher one. It's higher because the weight I use is not IBW. Then this one is the clearance total of digoxin, right?
Yeah. So now we are asked recommend um, maintenance dose of digoxin
Maintenance
tablet.
dose.
So so because we are using it for heart failure, we don't need to do the loading dose. Yeah, just straight away maintenance dose to achieve satisfactory steady state serum digoxin level 0.5 to 1. So which one you choose? 0.5 to 1 you can choose in the middle, yeah, maybe 0.8 or
The
maybe
middle,
yeah,
eh,
maybe 0.7 or 8, it depends, yeah.
7.
So
Yeah.
so it's fine if you choose 0.7 or you choose 0.8 is fine. And according to population data, so because we don't have any of this patient data yet, yeah, so we use population data. So what we do is we have to calculate the clearance total of digoxin, yeah, using this formula. And the clearance, the metabolism, yeah, metabolism clearance is 20 ml per minute, because this is for heart failure. Okay, so you just put into the calculation 1.303 times original
Clear.
the creatine clearance that we calculated, yeah, and then plus 20, so we get 74, okay, 0.41. Now because we choose 0.8 nanogram, so remember, yeah, you use nanogram. So then you put in the calculation CPSS equal to, this one is CPSS average kan, S times F times dose divided by clearance times tau, yeah. So we take it out the dose, so your this one you take it out the dose, so you want SPSS, right? So you have the CPS, the dose, because you calculate this one, so you want the dose, so your CPSS times clearance times tau divided by S times F. S is salt form, for digoxin it is 1, yeah, and then the bioavailability we use
1.
0.7. Okay, bioavailability 0.7, and put in here, and then there is a clear what interval is this? The now, so CPSS 0.8, yeah, clearance, the digoxin clearance, yeah, and then the tau, so this one is important because it's daily 24, yeah, but because we are using ml etc., so better you change to because we are using the minute, right, minute, yeah, so we change to day. So it's because it's between 1 day, so the 1 day we change it to minute, yeah. So the 1 day is 24 hours, and 24 hours times 60, yeah, so 1440. All right, then you divide by this clearance and tau, yeah. And because y times 7 here is the bioavailability, so you get 122.5, yeah. So 122.5 is close to 0.122, because this one is nanogram, yeah,
Yeah.
0.122, and then you don't have no, we just estimate, yeah, 0.122, so we can use the 0.125, yeah, because it's already like 3 decimal, right, behind the point, yeah. So we can safely say, okay, 0.125, yeah. Okay for this one.
Yes. So yeah. So the decimal point we use up to 3, is it?
You can use 4 also, but then it is
4.
in milligram, right? So we have only in our stock, yeah, 0.125, 0.250, 0.0625, right?
Okay.
Okay, so now we continue. 2 months later, Devi has a steady state serum digoxin level drawn. The lab reports this value as 0.5 nanogram per ml. This slightly low level is thought to be the reason why Davis heart failure symptoms are not controlled. Recommend a new maintenance dose to achieve a serum concentration of 0.8 nanogram per ml. So after the TDM, yeah, is 0.5, right? So as a pharmacist, what you do? What will you do before you calculate the dose?
Check again.
Huh?
Check again the level. Or
But every time you check the level, right, it will be costly. Or maybe dia answer ya. Poor dia. We cannot check for steady state the current one. Okay, steady state is one thing, yeah, because you need to wait around 7 days, yeah, for steady state, right? So you must check whether the level is already steady state or not. That is one thing. Another thing is that when the concentration is low, so we have to check what? Com, com,
compliance.
compliance, yeah. So because we don't know whether the patients comply or not, yeah. If the patients don't comply, of course the level will be low, correct or not? Yeah. So in that case, we should not adjust the dose so fast, no, so quickly. Yeah, you have to investigate first, because otherwise, if you already increase the dose, then what if the patient now become comply? Yeah, so it will be overdose. Okay. Now the CPSS measured now is 0.5, yeah, and your dose is 0.125 milligram, yeah. And now CPSS desired 0.8. So because this follow the linear, yeah, so we use the just a simple one, new dose, yeah, equal to our desired SPSS, yeah, CPSS, sorry, what SPSS, CPSS divide by the measured CPSS times the dose, yeah, we get 0.2, right? So the thing is that you can also use the long formula, yeah, finding first the clearance. After you find the clearance, you again, calculate the dose. Yeah, you can do that, but it is a bit longer lah. Yeah, and it will come to the same result as well. Okay, so if we cannot give if because 0.2 we don't have 0.2 tablet, yeah. So if we give 0.25, so it will be 1, yeah. If we give 0.25, so the estimation of the concentration will be 1, yeah. So if you are happy with 1, that's fine, yeah, you give 0.25. But if you are not happy, yeah, so we recommend to give so let me check what is happening. I think maybe I have to charge my computer. Am I? So if so, we recommend to give 0.25 and 0.125 milligram alternatively, meaning that on alternate day, yeah, on alternate day. So this is not alternatively, but on alternate day. So so it equals to 0.1875 milligram per day. So if we add in this one, we divide by 2, yeah, so per day is 0.1875. So then if you estimate again the concentration, yeah, it will be around 0.75, yeah, 0.1875 divide by 0.125. From where we get 0.1875? Oh, this one, yeah, the dose, yeah. So the recommended dose divided by the dose that we take previously times the concentration. So it will be around 0.75. Yeah, are we satisfied with 0.75? Yes or no? That's the best we can, right? Because we want to achieve 0.8. So now without breaking the tablet, etc., we can get 0.75. We are quite happy. Yeah. Because which one is better, 0.75 or 1.0?
0.75.
Yeah, because 1.0 is already in the limit, right? Yeah, the limit. Actually, the limit is 0.9 lah. Yeah, 0.5 to 0.9. But because I don't want to complicate things, yeah, 0.9 quite difficult. So I put 1. Easier for us to remember, right? 0.5 to 1 rather than 0.9. So normally we want to achieve 0.7 to 0.8. Yeah. So now Devi begins her new digoxin regimen, 0.25 milligram and 0.125 milligram on alternate day. So which is equal to 0.1875 milligram per day. 3 months later, Devi has a severe diarrhea and vomiting due to food poisoning. She complains of slow and irregular heartbeats. So does it correspond to digoxin toxicity? Yeah. So her digoxin concentration taken in the clinic today is 1. Yeah. Her potassium level is 2.1, 2.5, sorry. Serum creatinine is 90. Yeah. So her ECG shows bigeminy. Yeah, bigeminy. Every other beat is a primary ventricular contraction. So this is the normal one. Yeah, and then you have got PVC, normal one, PVC, normal one, PVC, normal one, PVC, normal one, PVC. Yeah. So at every other beat, you have got extra beat. Yeah, you have got extra bit in every other bit. Yeah, it looks like quite regular. Yeah, quite regular. Yeah, so this is called bigeminy. So assess what is happening to Devi and recommend how to manage. What is happening actually? Can you tell?
Is it? Uh,
What is happening? Yeah,
Toxicity?
is there any sign of toxicity
Hmm.
symptom? There's a
Slow and irregular heartbeat.
yeah, irregular heartbeat, and then also by Gemini. Yeah, so by the by Gemini, you already sort of you can suspect, yeah, this. But why the concentration is still okay, right? One is not too high.
Yeah.
Yeah.
The accumulation.
Accumulation.
The timing is not, maybe the timing is not the steady state timing.
How about Allah and dia? So what is not normal here? Is already here is the potassium is low. Yeah, so potassium is lower than the lower limit. Yeah, so 2.5, and potassium is so Actually, potassium is very sensitive, yeah, because potassium you only have 3.5 to 5, okay, 3.5 to 5, and if let's say you are less than 3, yeah, so you have got the risk to get into arrhythmia. If you have above 5, then you get also a risk for arrhythmia, yeah. So the ventricular uh, um, bradycardia, yeah, and uh, if you have, I mean that, so you have got arrhythmia, risk of arrhythmia. So you, so this patient has 2.5, yeah. So you already have the risk of arrhythmia, and then for the digoxin, okay, the MOA of digoxin. What is the MOA? Yeah. So the MOA is actually it inhibits the sodium potassium pump, right? So these are the sodium potassium pump, yeah. So so the mechanism is actually inhibiting this one, yeah, so that no potassium will come in, yeah. So if no potassium come in, so there is less not sodium will go out. If less sodium go out, yeah, and it will prevent sodium for coming in, because there's another pump, yeah, another pump exchange, yeah, between sodium and calcium. So normal, in the normal one, yeah, the sodium will go in and calcium will go out. But because now this sodium cannot go out, yeah, because the potassium cannot come in, sodium cannot go out. So sodium is accumulated into the cell. Yeah, because of that, there is no movement of sodium from here. And there is no movement from calcium to go out also. Yeah. So when there is no movement from calcium to go out, so the calcium also will be accumulated in the cell. Yeah. And the calcium that is increased or accumulated in the cell will go inside the sarcoplasmic reticulum. And when it goes to the sarcoplasmic reticulum, it will disturb the other calcium there, and all the calcium will be released. Yeah, so from the sarcoplasmic reticulum, all the calcium will be released. Yeah, triggered to be released. So when you have the release of calcium, so calcium is for the contraction of muscle. Yeah, so when there is a lot of release of calcium from sarcoplasmic reticulum, so it will increase the contractility. Understand the mechanism of action of digoxin?
Yes.
Yeah. So now let's say if you have, because digoxin prevent the coming in of potassium. Yeah. So it means what? It means inside the cell, yeah, by right potassium will come in, right? Yeah. If you have digoxin, you will decrease the potassium coming in. Yeah. So if you have got already lack of potassium, yeah. So in the normal sense, your potassium, it will not come already, yeah. And on top of that, you have got digoxin. So the digoxin activity will be double, yeah, will be double, because the potassium will not be, even less potassium will go in. Understand or not?
Yeah.
Yeah, because the normal one, the digoxin will inhibit the potassium coming in. Yeah. So now your potassium is less. Yeah, less. Outside is less. So the digoxin will be like very relaxed lah, correct or not? Yeah. It
Yeah.
doesn't have to prevent the calcium, potassium, the potassium to come in, because you already lack of potassium. Yeah, so the digoxin will be okay, relax, yeah, meaning that the digoxin activity will increase. Yeah, because with this dose you only need, yeah, you actually don't need to have a higher dose, because you are relaxed already, you have lack of potassium already. Yeah, but now you the normal dose of digoxin, and you have got this situation, so your activity, actually the digoxin activity is increased actually. Yeah. So and then what causes the hypokalemia is because the patient has food poisoning, yeah, which cause the vomiting, yeah, and diarrhea, vomiting and diarrhea, yeah, and this vomiting and diarrhea can cause hypokalemia, yeah, vomiting and diarrhea. May cause hypokalemia, yeah. And then in hypokalemia, the effect of digoxin will be amplified, yeah, will be increased. And this is a pharmacodynamic interaction, yeah, in the site where they work, yeah. So the digoxin level may not increase, yeah, may not increase, yeah, the digoxin level may not increase because there's no it does not disturb the pharmacokinetic of digoxin, yeah, so the level will not may not increase. Okay, so the management just to correct the potassium level, easy, right? Because you have, because the cause of this is the lack of potassium, yeah. So now what you do is just to increase the potassium level, and increase the potassium level, do you, it will take time or it will be fast? What do you think?
Take time.
Huh? Because dia suggest to stop digoxin. So if let's say you need maybe 1 or 2 days to increase the potassium, then you have to stop the digoxin lah. Correct or not?
Yeah.
Yeah, until the potassium level is normal. Yeah, but when you administer potassium, if you need a faster action to reverse the hypokalemia, you can use the IV or not.
Mm.
You can use IV potassium chloride. Yeah, so if you use, of course you don't, if you are in a hurry, you want to increase, yeah, you want to increase the potassium, yeah, don't use the slow K, because slow K is called slow, yeah, so it will be bit slower, okay, because it's slow release, yeah. So you must use the immediate release one, yeah, or you use the IV. Better to use the IV one if you need a faster response. Yeah, give IV. So then within minutes or within an hour or so, because you cannot give potassium too fast as well. Yeah, you have to give it slowly. Yeah, but slowly also not until more than 1 hour lah. Yeah, so maybe within 1 hour, half an hour to 1 hour you give. Yeah, so that time then you will resolve already, yeah, so you probably will not no need to stop the digoxin, yeah. So now after the matter is rectified, Devi continues with the same regimen of digoxin, yeah, 0.1875 milligram per day. A year later, Devi reports to her physician complaining of, what is this? Nausea and vomiting, yeah. So I just type wrongly like this. Complaining of nausea and vomiting. A serum digoxin level 10 hours after the last dose. Why 10 hours? Just now we know already because of the distribution, yeah. And serum creatinine are drawn. Her digoxin concentration is 1.6 nanogram per ml, and her serum creatinine has risen to 170 micromole per liter. Recommend a new dose to achieve 0.8 nanogram per liter. And how long should the digoxin be withheld before starting the new dose? Yeah, of course, because it's high, 1.6, you have to withhold. And the patient already have kidney failure or kidney impairment at least. Yeah, because now the serum creatinine is increased to 7170. Okay, so our measured concentration is 1.6, the desired one 0.8. Yeah, is totally half. Yeah, okay, so what we need to do, yeah, just to calculate the new dose, yeah, 0.8 divided by 1.6 times the dose. Yeah, this is the dose that you're using. So we got 0.09375 milligram, yeah, per day. Yeah, so for this one we can't give 0.0625, right? It's too far away. Yeah, so we can give 0.125 milligram and 0.0625 milligram on alternate day. Yeah, because if we calculate this one, yeah, and we divide by 2, yeah, it is almost, yeah, almost this. Okay, okay, so we give this one. Yeah, so our daily is 0.09375 milligram. So we want to know from how long this drug should be withheld. Yeah, so we need to calculate this one. Yeah, C2 equal to C1 times E min KT. So ln C2 ln C1 min KT. T, this move here. So T equal to ln C2 minus ln C1. Yeah. So if ln C2 minus ln C1 is same as ln C1 divided by C2 and divide by K. Yeah. So now we don't know the K. We don't know the K. So we have to get the K using the population data. Yeah. So we know the creatinine clearance, calculate again because it is said now the creatinine, serum creatinine has increased to 170. Yeah. So we calculate again the creatinine clearance is 21.7 milliliter per minute. Yeah. And the digoxin clearance, we use that previous formula and we get 2.9 liter per hour. And then VD in ESRF is end-stage renal failure. Yeah. So earlier it is says that for renal failure patient, yeah, less than 10 milliliter per minute for the clearance. So we can have the VD because VD normally is 6 to 7. Yeah, but because in tropical countries and smaller country, what am I talking? Okay, say 4.1 plus minus 10, right? As 1, yeah. But this one is for less than 10. Yeah, so now the patient is not less than 10, it's 21. Yeah, still okay. Okay, so we become a bit generous lah because it's plus minus 1. Yeah, so now we take 5 lah, just plus 1 lah. Yeah, 5 liter per kg. This one is just an estimation. Yeah, then we get the K. So we calculate the K. The K is clearance divided by VD. Yeah, so 2.9. So we have to, this one we have be aware. Yeah, we have to calculate, we have to convert first ml per minute, convert to liter per hour. Yeah, and then we have 2.9 divided by 5.52.2 becomes 0.011. Yeah, and then we put it here to the K. All right, then we get 63 hour. Yeah, so we need 63 hour. So we must wait around 63 hours. What 3 days is around 72 hours. Yeah, so we probably can say, okay, wait around 72 hours. Okay, so this is the last one. Any question just now? This one? Any question? So don't forget that digoxin also has got drug interaction. Just now I mentioned in the previous slides. Yeah, drug interaction, and then digoxin also can be can use antidote, yeah. The what do you call this? The antidote. Uh, I think I have one slide lah for that. The antibody one, yeah, the antibody. So the antidote is the digibind, yeah. Maybe somewhere earlier slide. I'm sure that I have. Digibind in the monitoring, I think. The digibind, yeah. Okay. So for that, those calculation, do you have any question? No? Easy, yeah?
Okay lah.
Yeah? No question, yeah?
No, no, yeah. I need some time to digest the calculation for a while.
Oh, really? I thought this is very
Yeah.
easy.
But the last one,
The last one, okay.